Well, hello again, and welcome to our Advantage Lunch and Learn for the month of August. I can't believe we're already in the 8th month of this year and how time has been flying so quickly with everything related to COVID and the change that has interfered with our lives. I hope you're also able to stay as cool as you can with the summer heat that has been upon us recently. Our discussion today is going to be related to heart disease. And what do we mean by all these different terms for heart disease? Because it can be quite confusing. I'm Kevin Ewanchyna. I'm a family doctor by training, and I have been Chief Medical Officer of Samaritan Health Plans for the last 10 years. I've been a practicing physician with Samaritan Health Services and will be completing my 24th year. Hard to believe how quickly time has gone by, but I'll be completing my 24th year in just 2 weeks' time. It's been a wonderful journey, and my most exciting component of being part of Samaritan is really interacting with patients, with our health plan members. So thank you for that opportunity to be in front of you today. My wish would have been still to have done this live because I get a lot of personal satisfaction of interacting with people one-on-one, but our virtual Teams format will have to suffice for today. Along with myself is Danielle Hunter, part of our Medicare programs, and we'll be able to answer some questions related to benefits as well a bit later on with the presentation. As I said, our Lunch and Learn topic is going to be about heart disease. So, heart disease, and what do we mean about all these different terms that your doctors, your clinicians may talk to you about? We've heard the term angina. Well, what does that mean? What is the difference with coronary artery disease? Does that mean the same thing as a heart attack? What does it mean if my doctor or clinician has said I have heart failure? Also, we have terms of sudden cardiac arrest. You may have heard your clinicians talk about pericarditis, endocarditis, or myocarditis. So we'll be talking through some of those terms as well. And then arrhythmias of our heart can present in forms of what we call atrial fibrillation. Those are the two top chambers of the heart, or ventricular tachycardia. And the ventricles are the two bottom chambers of the heart. They're the more muscular chambers that send all the blood going throughout the body or to our lungs. So next slide. So these are general risk factors for heart health. And this doesn't mean if you have 1 or 3 or 5 of them that you always will have things that affect your heart, but these are still diagnoses that you and your doctors, your clinicians have to watch for. And first and foremost is high blood pressure. We use the clinical term hypertension. And right now, of course, everybody can be quite variable, but we say a normal blood pressure reading can be in the 120s systolics and about 80s diastolics. So there's two numbers that are calculated when your blood pressure is checked. Now, as we age as well, our arteries get a little less elastic and our blood pressure can start to rise. So it's always important to look at the appropriate blood pressure that's right for you with your clinician. But again, in general, 120 over 80 is our standard of what we say is a normal blood pressure. Now, many people have had for years low blood pressure. Low blood pressure in its own is not related to overall heart health issues as well. It's usually more related to having high blood pressure that is not controlled. We also know that men, unfortunately, have more of a risk for developing heart disease than women, but women start to catch up with us in those menopause, postmenopausal years. We also know that food that is high in saturated fat, probably the food that I should be avoiding as much as possible because I like myself a juicy rare steak, but that saturated fat is pretty high in animal meats. And bacon. Bacon's another one of my favorites. But food high in saturated fat can give high blood cholesterol, can increase your triglycerides. And triglycerides are that component of your fat. They're a combination of both cholesterol or fat and sugar together. So trying to avoid foods that are high in saturated fat, foods that are higher in triglycerides are helpful for heart health. Another risk factor is the absence of physical activity. And anytime that you can move your body in any format, even if it's what I used to like calling armchair aerobics, if you find your knees or your hips are giving you problems and you can't get out for a walk, we can still exercise our heart by getting some free weights into our arms and doing some arm lifts with the weights while we're sitting, putting these weights on our lap of our thighs of our legs and raising up our knees back and forth to at least exercise our legs. So trying to move your body in any ways is always a good thing to do when we're trying to reduce our risks for heart health. Also, using tobacco in any form, whether it's smoking it or chewing tobacco, are risk factors for heart health, and it's because of the nicotine effect on our heart itself. Also, the presence of type 1 diabetes and type 2 diabetes. Type 1 is usually that form that occurs in childhood or adolescence or sometimes early adulthood, but it's where we need insulin daily just to keep surviving. Type 2 diabetes happens later on, usually when we're an adult, and you might need insulin, but usually before that, you might be able to control it with diet, with exercise, with medications, and with insulin. Chronic kidney disease is something that we don't talk enough about. It's often hidden, and there's various stages of chronic kidney disease, stage 1, 2, 3, 4, and 5. And the problem with chronic kidney disease is that we don't have a lot of symptoms of our kidneys that are starting to fail us until we're potentially in stage 3 and beyond. So it's a very silent disease in stage 1 and 2. But these are also general risk factors for our heart health. Family history is a big one. And we know that people will do everything right, not smoking, not drinking, not eating saturated fats. They're always active, and yet they still may have had a heart attack. And we know that there are certain clusters of heart attacks that can run in families. So it's important to understand and recognize our family history and talk about that with our clinicians so we can get a good reading on our own risks for heart health. Advancing age, we can't do anything about that, unfortunately. Being overweight or obese. We do know that stress is a risk factor of heart health. And there's actually a condition, a broken heart condition, due to increased stress that has actually given a heart attack because of stressful incidences. So it's important to recognize your stress levels. Also important to see what we can do to reduce unhealthy stress levels in our body. Alcohol is another risk factor for overall heart health. You know, there used to be a time, just even as to a year ago and more, that we used to talk about having a drink of wine, that wine was heart healthy. And we now understand that a lot of those studies were done in error. And the newer studies are now showing that even a little bit of alcohol intake may be damaging to our overall body, which includes our heart. So we definitely want to watch our intake now, and we've kind of changed our recommendations about heart healthy wine intake, for example. This may be something that you have heard your clinicians talk about because of some of the antioxidants that were in wine. But unfortunately, a lot of those studies were flawed, and many of the studies were actually produced by the wine industry. Sleep, too little or too much sleep, and a condition called sleep apnea. Which is a risk factor for heart health as well. So the appropriate levels of sleep, usually around 7 to 8 hours a day for adults, is beneficial. They've actually found a recent study with people that are taking naps in the daytime may be at risk of heart health versus people that don't take naps in the daytime. So again, this is just a general risk factor that we want you to be aware of, and we'll move to the next slide next. So I've talked about the term angina. Well, what does that really mean? Angina, it's a symptom. It's something that we feel. It's not a disease itself. So nobody can tell you you have a disease of angina, but you may have the feeling of angina that comes along due to underlying heart disease. And this is where we get that chest discomfort when the heart muscles receive less oxygen. And we need oxygen-rich blood going through our heart, throughout all of our body. And if there's a blockage in the coronary arteries, these are the arteries that feed the heart itself. If there's a blockage there, it can give this chest discomfort that we call angina. Stable angina means that it follows a pretty regular pattern of frequency, meaning it occurs within 20 minutes of going for a walk. All the time, you rest, it goes away. That means it's a stable angina. But unstable angina is more worrisome. It's chest pain that occurs very suddenly because of blood flow from a fatty plaque that gets ruptured, producing a clot in the artery. This usually will get worse with rest, not better. And this usually is a medical emergency. And that is something that we would have people go right towards the emergency room with, this feeling of unstable angina. But again, angina is only the symptom itself. It's not a disease. Next slide. So coronary artery disease. This is where we talk about the disease state itself. And that means it's the condition where the major blood vessels, the coronary arteries themselves, become narrowed. And this then starts to decrease the amount of blood flow. And this causes this angina, this symptom of chest pain. It can also give shortness of breath. And if there was a complete blockage in one of the arteries of the heart, it can then cause a heart attack. We'll talk a little bit more later of what a heart attack is specifically. But cholesterol deposits, or what we call plaques in the heart arteries, and equally the inflammation that occurs due to those deposits or plaques, are the usual causes of coronary artery disease. It's something that usually develops over decades, and your warning symptoms of coronary artery disease initially developing are not there at all. So these symptoms will go unnoticed until you have a significant blockage that would then produce this feeling of angina. Next slide. So common testing that we use in workups for the heart is an EKG. This measures the electrical activity of the heart, and it only measures the electrical activity at that given moment in time. It can't measure what your heart was doing yesterday. It can't measure what your heart will be doing tomorrow. It's just those few 30 seconds of while the heart tracing is being done. But it can start to detect damage that may have occurred in some areas of the heart. Another common test is an exercise stress test, and this monitors your heart activity. So it will do real-time monitoring of your EKG while you're walking on a treadmill. And then the treadmill speeds up or it goes up in an angle, and it measures the ability of the heart to pump blood faster. It also measures the electrical activity while it's pumping that blood faster. A nuclear stress test. This is where you'll have a tracer that's injected into your blood vessels through an intravenous. And this will go through the heart and obtain images of the heart while it's at rest and then while they're speeding it up as well. So it may be sped up while you're on the exercise stress test, or it may be sped up while they're giving you a medication to actually speed up the heart itself while you're sitting or laying. And that's called a nuclear stress test. Angiogram. Angio meaning heart, and a gram meaning basically a picture. And CT, a CAT scan. So a CT angiogram looks for narrowing or blockages using a dye that again goes through the intravenous, goes through the heart vessels, and then they do a CT scan. It's done with a computer, computerized tomography, and that's what CT stands for. Then lastly, a cardiac catheterization. This is inserting a small little tube into the blood vessels of the heart itself to look for narrowed arteries. And they can tell then if there's a blockage occurring that is not feeding the heart muscles appropriately with oxygen. This is done real time, usually in what we call a cath lab. So this would be done in the hospital setting with the cardiologist there watching. Next slide. So a heart attack is damage that occurs to the heart muscle when we get a loss of blood supply due to that blockage in the artery. And heart attack symptoms can be completely severe with that Hollywood presentation of person clutching their left chest, falling down to the floor and not being able to breathe. It may be also very mild with just a feeling of upset stomach and nausea, or it may be no symptoms at all and a person just collapses. But most commonly, it's chest pain that would feel like a pressure or a feeling of tightness in the chest area. It may be a squeezing feeling, or it may just be like a dull ache. And sometimes this ache or squeeze or pain can also spread to either shoulder, more commonly going to the left shoulder, could go to either arm, but most commonly going down the arm, maybe in the middle of the back. We might also feel this somewhere in the neck, in the jaw, in the teeth, even sometimes the upper belly. So that feeling of indigestion with knowing that there was really nothing you took in terms of food to cause indigestion for you could be a warning sign of a heart attack. So we want to listen to our bodies. Also, a feeling of going into a cold sweat or having just unusual fatigue that is very, very new and different for you. Heartburn or indigestion, a feeling of lightheadedness or sudden dizziness, and then nausea or shortness of breath. Next slide. So how do you do to test for that heart attack? We talked about the EKG already, and this is where you see the little electrodes are placed all over the chest wall and on the side, and then it does this heart tracing of various areas of your heart over about a 30-second period. But also there's specific enzymes that are leaked into the blood when there's damage that occurs in the heart muscle cells themselves. And those enzymes will go into the bloodstream and they're collected then and analyzed to see if they're present or not and if they're increasing at a rate or not. So they may do one initially and then do a serial enzyme of the heart muscle in an hour or 2 hours to see if they've gone up from that time period. Next slide. Heart failure. This is a condition where it's a progressive disease that affects the pumping action of the heart. So it's not a problem with the electrical action, it's a problem with the muscles of the heart chambers themselves. And it can cause fatigue, some shortness of breath. Some of the earlier signs that would be warning signs of heart failure might be swelling or water retention, and especially if it's new or different. So this is where blood pressure control is very, very important. Also, if you notice that you weigh yourselves on a weekly basis and all of a sudden you've gained 3 pounds in weight and you don't know why, and you look down and you see that your feet and your ankles are really, really puffy, or your face looks puffier than usual, and you can push down into your ankles or your lower feet, and if there's a large indent in there, it means that you have too much fluid in your legs. And part of that increased fluid may be due to your heart not being able to pump all of that blood forward. So it leaks then into your lower legs, can also leak into your lungs, and that's what can give some feeling of shortness of breath. So we want to make sure that anybody that has a rapid weight gain really has that assessment to see what's going on. Heart failure can also sometimes give some irregular heartbeats as well. It could come along with some chest pain, and in very severe cases of heart failure, again, that the heart muscle not being strong enough to pump all the blood forward, you don't get enough blood going to your brain, and you would faint very, very suddenly. That's usually in very severe cases. Next slide. So how do we test for heart failure? Well, we usually do our usual test to make sure that there's no disease that's occurring in any of the heart vessels. And that's where I talked about cholesterol levels before, but also kidney function. We want to make sure that things called our blood urea, our nitrogen, blood urea nitrogen, our creatinine levels in our bloodstream are working normally. But thyroid function, if your thyroid gland, which is located right in your neck, was underactive or overactive, it can give some problems with heart function. So this would be another blood test that we would check on patients. Also making sure a complete blood count is done, and that would check your white blood cells, your red blood cells, because if you are anemic with having low red blood cells, this could be an underlying reason why some people enter into early heart failure. And then lastly, this BNP. This is a blood test that's specific. It has to be ordered specifically like this. It doesn't show up in just a blood count or a metabolic panel, but it stands for a B-type natriuretic peptide. And if this BNP level is elevated, it's a sign that there are degrees of heart failure that are going on. A chest x-ray might also see there's enlargement of the heart that's seen in the x-ray, or they could see fluid that's in the base of the lungs. Going back to that EKG, they might be looking for rhythm disturbances that are causing some heart failure. You can also see enlargement of areas of the heart muscle that are seen on the EKG as well. And then the echocardiogram, this is where it's really looking at a real-time picture of the heart itself. So very similar to pregnant women that are having ultrasounds done of their babies. This is where it's an ultrasound that's looking at the size of the heart, the function of the valves, and how quickly, how much of the blood is moved forward with one beat. That's called its ejection fraction. Also, another test for heart failure might be a stress test. And that again is like a treadmill test, measuring the amount of stress that can be sustained during activity. And then we talked about cardiac catheterizations as well, and that's checking for those blockages in the coronary arteries. Next slide. So a sudden cardiac arrest. This is a condition where all of a sudden the heart stops beating suddenly, and it's caused by an electrical disturbance within the heart. And this is different from a heart attack. This would be the situation where somebody is walking in the mall doing some shopping, and then all of a sudden they go down suddenly. It's an abrupt loss of heart function. It's an abrupt loss of breathing and an abrupt loss of consciousness. And the emergency treatment at that time is activated, where bystanders that are trained in CPR start to do compressions. They activate EMS, which is calling the ambulances, taking people right to the emergency room. And if people are lucky enough to have defibrillation packets available, many workplaces will have them, public spaces will have these, and you can do an immediate defibrillation, which could potentially reverse the cause of the sudden cardiac arrest, but it's due to an electrical problem. Next slide. Myocarditis. This is when we talk about damage, inflammation to the heart muscle. Myo means heart itself, which is different from the other terms I'm going to talk about, the pericarditis and the endocarditis as well. Myo means the heart muscle. And it can commonly be caused by a viral infection, sometimes bacterial infections or fungal infections, parasites, or we do know that reactions to drugs like chemotherapy agents have sometimes caused a myocarditis. As well, in people that have an autoimmune condition called lupus, they may be more exposed to predictors of myocarditis than people that don't have lupus. And then exposure to radiation, heavy metals, various medications. You know, we don't see rheumatic fever anymore, or we don't like we used to. But in the days where we had a lot of rheumatic fever that was around caused by strep infections, this was an underlying cause of myocarditis. Recently, with COVID vaccines that have been given over the last couple of years across the world, we see that there is a link with myocarditis and COVID vaccines, and more specifically, more commonly in young men. But this is only about 20 people in 1 million vaccinations that might have a myocarditis with the COVID vaccine. And it's important to know that if we compared the amounts of heart injury or myocarditis with actually getting the COVID infection, it's estimated to be 100 times higher. But I do put it out there because some of you may have seen that myocarditis has a link with COVID vaccines, and more specifically, again, in young men. We're not really sure why, but we do track that. Next slide. Endocarditis. This is really that inflammation that's affecting the inner linings of the heart valves and the chambers that you can see. So just the inner areas, not affecting the heart muscle, the myo component. And next slide. And then pericarditis. Peri means external or outside, and this is the inflammation that affects the sac around the heart itself. And sometimes that sac can become so thickened from pericarditis that it prevents the muscle itself in the heart from beating appropriately. And it can then cause various symptoms. Next slide. So now we get into some of the heart electrical disturbances. And atrial fibrillation, or something we've called AFib, is becoming more and more common. And it's a disease of the heart that can give irregular and usually often faster heartbeat. But sometimes it may be just a feeling of a little few blips or flips in the heart itself, where you can feel it going a little faster for a few seconds, and then it goes back down to a normal speed. But it's the most common type of heart rhythm disturbance that we see. And symptoms of atrial fibrillation or AFib, you might feel those palpitations, a pitter-pattering going on in your chest. You may feel short of breath or have some weakness. You may experience increased fatigue or tiredness, the decreased ability to be physically active. You still could have some chest pain that could occur, and you might feel lightheaded or dizzy. Also, confusion may be an underlying symptom or feeling of atrial fibrillation. And this is due to the damage of the heart's electrical system itself. We know that there's a lot of things that can start to produce this damage to the electrical system. And I'm going to go back to alcohol and what we used to think was the right approach for alcohol intake and heart health. But we do now understand that alcohol consumption is considered a risk factor for people that develop atrial fibrillation. And if a person does have this specific diagnosis, it is recommended to not have alcohol intake because it can make your atrial fibrillation symptoms worse. Also, we know as the heart ages, the electrical system can sometimes have some aging and wearing of that as well. And that's a risk factor for atrial fibrillation. But uncontrolled high blood pressure. If we have high blood pressure and we keep it uncontrolled over years, it can start to wear down the heart's electrical system and then start to produce this condition called atrial fibrillation. Also, people that might have heart valve problems, so whether it's what we call stenosis or narrowing of the mitral valves, the tricuspid valves, this can be a cause of underlying atrial fibrillation. Or various stimulants. We know that nicotine and tobacco will increase the heart rate, and it can make your atrial fibrillation worse. Also, stimulant medications like ADHD medications can increase your heart rate and can predispose you to getting atrial fibrillation as well. And then prior heart surgeries, when there's scar tissue that occurs, that scar tissue from heart surgeries can impact the electrical system of the heart and could bring on atrial fibrillation. Also, the condition of sleep apnea, and we've talked about sleep apnea and other lunch and learns, but that's where during sleep, the ability to keep breathing appropriately is compromised. It's like the back of the throat basically shuts off and you don't breathe well. And it can actually increase the potential for atrial fibrillation to occur and other heart problems as well. Next slide. So if AFib, if we leave this untreated, what can happen? Well, we start to get little blood clots will form in the heart chambers because the heart atrium, the top chambers of the heart, are not acting appropriately to get all the blood out. So that blood kind of recirculates, regurgitates in the atrium, and it's like the atrium are quivering. They don't contract in one full beat, they quiver. And this leads to the development of small little clots that will form in those atrium. And then those clots could potentially start to go into the heart vessels or go into other organs like the lungs or the brain. And that can predispose people towards getting a blood clot in the lungs or a blood clot in the brain, which would produce a stroke. But also the atrial fibrillation, the quivering of the atrium can start to develop heart failure as well because there's more pressure being then placed on the lower chambers of the heart. And it can give chronic fatigue because the heart is not pumping appropriately. This can start to reduce the blood supply to organs like your brain, like your gastrointestinal system, like your kidneys, and it can start to produce kidney problems. So how do we really diagnose atrial fibrillation or AFib? We can sometimes pick it up on an EKG. We might have people sent to the cardiovascular department to pick up a Holter monitor. And this is where a little electrode is placed on your heart area, and you wear almost like a battery pack for the next 1 to 3 days while this little Holter monitor is measuring your electrical system of the heart over the next 3 days. We also have a ZIO or a ZIO patch, which will do very similar things. And then also that echocardiogram, that's the ultrasound of the heart, that can sometimes pick it up as well. Next slide. VTach or ventricular tachycardia. This is again a fast heartbeat, but it's of the lower ventricles versus the upper two atrium of the heart. So the lower part of the ventricles, the part that push the blood forward, are beating very, very fast, and we'll feel a very fast heart rate. And this can give electrical signals that are irregular in these lower chambers. Next slide. So this can then prevent the heart chambers from properly filling with blood. And because they're not filling appropriately and not being pushed out to the rest of the body, we can start to develop shortness of breath, chest pain, lightheadedness, or even a person may have sudden consciousness loss. And some of these episodes with VTach may be only a couple of seconds where we might not even feel it, but it might be as long as 30 seconds where we're feeling very, very fast heart rate, but then it suddenly stops and it hasn't caused any harm. But episodes that are lasting longer than that 30-second mark can be life-threatening and then can cause the heart to all of a sudden stop. And that's where we have that sudden loss, that sudden cardiac arrest that I was talking about earlier. So next slide. So the most important thing about these terms that I've been talking about today is that it's meant really for education so that you're aware of what terms mean what, because it can be confusing. It was not meant to diagnose certain conditions because that is really left towards you and your clinician. So I don't want to diagnose any conditions in a virtual Teams meeting. And we also do have the caveat that if you have questions regarding your specific heart condition, I would always want you to see your primary care provider or your heart specialist. But a few questions that were coming in earlier that I wanted to address is some of those early warning symptoms of congestive heart failure. And that's where we really want to look at our fluid changes that might be occurring in our system, watching for any swelling of our face, of our hands, are rings tighter than they normally would be, and it's not due to heat. Whenever we have hot, warm days, things are always going to feel tighter in our body, but it would be those changes in fluid levels that are affecting our legs and ankles, our swelling of the hands or face that aren't attributed to summertime and being extra hot. Also, we watch salt balances. So having too much sodium or salt in our diet can start to give those imbalances as well. So I would watch for those early warning symptoms of congestive heart failure. There's also a question that came about stents. And what exactly is a stent? Well, there are a couple different types of stents, some that are almost acting like physical barriers in that plaque, that narrowing of the heart arteries that I had talked about before. And they're placed there to allow the heart, the blood flow to go through that narrowed space rather than it being restricted. But there's other stents too that have a medication in them. They're called drug-eluting stents, and they may help to decrease the amount of clotting that might occur where the stent is placed. And the stent is placed in the narrowed parts of the arteries so that the symptoms of angina are decreased. And so that's one of the treatments for severe cardiac disease where you have the narrowing of the arteries producing your symptoms. I am now going to turn to my colleagues to see if there are any questions that may have arisen in the chat feature, but we'll also watch if anybody does have a question that they wanted to pose. You could raise your hand and we'll watch for that and then call you by name if you wanted to ask that question.
Yeah, and Dr. I'd like to take just a minute here to talk a little bit about the benefits for some of the tests and procedures that you talked about.
That would be great, Danielle. Take it away.
So this is just kind of a really high level look for some of those things. A lot of the testing for cardiovascular disease is covered at no cost on all of our plans. So your annual wellness visit and the annual physical exam that we also cover, those are free. Cardiovascular disease risk reduction visit. So this is something that's a Medicare covered benefit that you can have once per calendar year. That's no cost. Cardiovascular disease testing, and if you need the lab tests or an echocardiogram or exercise stress test, those are all no cost to you. If you do need a chest x-ray, all of our plans cover x-rays with a $15 copay. CT angiograms would be covered at a 20% coinsurance. And then if you do require cardiac catheterization, that's treated as an outpatient procedure. So the cost sharing for that is going to be dependent on where you have that done. So if you have it in an outpatient hospital treatment room or an ambulatory surgery center, that can vary on some of our plans. So for Premier, if it's outpatient hospital or ASC, that is a $250 copay. For Premier Plus, outpatient hospital is a 15% coinsurance, and ambulatory surgery center is a $250 copay. On conventional, outpatient hospital is a $200 copay. Ambulatory surgery center is a $250 copay. And then if you're on our special needs plan, which is our members who have both Medicare and Medicaid, on the Medicare side of things, it's a 20% coinsurance, and then your Medicaid plan would pick up the remainder of that amount. So you end up not paying anything out of pocket for that service.
Thank you so much for that overview, Danielle, about the benefits. And does anybody have questions for Danielle about the benefits or myself about any of the topics or definitions that we had covered today? And Susan, I see that you've raised your hand. Please proceed with your question or comment.
I took the slash off and it went back on again.
Oh, we can hear you.
Okay, good. So you said sudden weight gain. Could you say more about that?
Yeah, what we say about sudden weight gain, if there was a big change from one week to the next where there was about 2 to 3 pounds in extra weight, and it's accompanied by fluid, where your ankles, your feet are feeling a little more swollen, we would want to make sure that your blood pressure is checked, and that especially if you had a diagnosis of heart failure already, that we were wanting to do some blood test to check the status of your electrolytes, your sugars and salts that are in your bloodstream, but also this blood test of the BNP that I was talking about.
Okay, and then I have another thank you question. I think this is Danielle, because I just made my appointment with my primary care physician at Samaritan, and I said I wanted an annual physical, and she said, well, Medicare doesn't cover that. We have to call it something else. We'll just call it an appointment. So then I'm looking, this is a nurse in the office. So then I'm looking, should I have said, ask for a cardiovascular disease risk reduction visit instead?
So there may be some confusion with your provider's office because they are correct that Medicare isn't like original Medicare. So if you only had the Part B, you didn't have an Advantage plan with us, she's correct that they do not cover a physical exam. But because you're a member of Samaritan Advantage, we offer that to you as an extra benefit. So I think we should probably do a little bit of follow-up if you don't mind sharing which clinic that you're going to so that we can give them some education about.
No, it was, the nurse was Carrie in Dr. Niehause's office.
Thank you. Yeah, and they can always call us too, you know, if you're sure this is something that's covered, they can always call us and verify that. They have ways to contact customer service so they can know that we cover those exams for you.
Okay, thank you.
And that was a great comment and question, only because many of our clinics in Samaritan will get confused with straight Medicare and then our Samaritan Advantage, which is extra benefits and extra bonus. So we'll make sure that we do that appropriate reach out to our clinics so that they understand that difference. Okay. Any other questions or comments? All right, we timed this pretty well today. We usually like to get to about 45 minutes to 50 minutes and give everybody that extra break before they get to the top of the hour for their next activities. But we wanted everybody to still be aware. This video, the recording of it, will be sent out by an email about 1 to 2 weeks afterwards, and that's just to allow time for the formatting of it. Also, we have a survey that will be sent out by email as well, along with this video. And during this survey, we really like to hear from you as to what you liked about this specific Lunch and Learn topic and format, and ideas for future topics. And then also, because we want to extend our thanks to you, and we weren't able to do this with our regular in-person Lunch and Learn, we will have a gift card that will come out to you in about 4 to 6 weeks afterwards. And this gift card is our compliments that you could spend at your local stores for something to buy for lunch or to put towards gas purchases, etc. So it's our thank you to you for attending today. So with that, extra special thanks to our Samaritan Advantage members. We would not be a health plan without having health plan members. So you are the complete focus and around everything that we do. So I thank you for being part of our health plan, and also thank you for your attendance today. So with that, I'm quickly gonna, of course, I'm doing Teams again, trying to get my camera on so I can wave bye to you, but it is not working. Oh, there we go. So thank you very much for your attendance. Hopefully there'll be a time in the future where you can do this live in person, but I do appreciate your ability to interact through our virtual format today. And I do hope that the information that was shared gave some better highlight of various terms that we use in the medical field, and it's meant really as a educational format for you. So thank you so much for joining us today.
Thank you, everyone. Have a great